Hello. Today we continue the topic of hypotensive drugs and the part of hypotensive agents of myotropic action and diuretics. These all drugs also refer to the hypotensive drugs because they all can reduce blood pressure by different mechanisms. Okay, and we start with the hypertensive agents of myotropic action. So they are calcium channel blockers of verapamil group and the group of nifedipine, potassium channel activators, and venous vasodilators, and the inhibitors of phosphodiesterase. Okay, please guys, pay attention on that. Here we have calcium channel blockers, but potassium channel activators. Yes, the different approach to the channels because they have different functions in the cell. Okay, and talking about the first group, calcium channel blockers. Why this is very important to maintain the low level of calcium inside of the cell. How do we actually get calcium inside of our cells? The level of intracellular calcium, the level of intracellular calcium, it depends on many different transporters and many different systems. Let's see what are they. The voltage-gated calcium channels we have, which depend on the membrane potential. Yes, the more is membrane potential, the longer opening of this voltage-gated calcium channels we have. Ligand-gated calcium channels, they depend on the ligand. Ligand, this is a kind of molecule which can interact with the channel. Yes, it can be a drug, it can be a signal molecule from the body, something like that. Sodium calcium exchanger, it's the antiport of the sodium and calcium ions, which move against each other. And also we have the active transporter, the calcium pump. Calcium pump, which is also an exchanger. It will exchange calcium with the ion of hydrogen, H+, with the use of energy, ATP. Okay, these all transport molecules which carry calcium from the outside of the cell to the intracellular space. And also inside the cell, we have very important endoplasmic reticulum, storage of the calcium ions. You see these red dots, they are also calcium ions. And intracellular endoplasmic reticulum, it is the site of deposition of this calcium. And we also have a very important calcium pump, which is also ATP dependent, which takes calcium from the endoplasmic reticulum to the outside of the endoplasmic reticulum to the cell. Yes? No. Opposite. Sorry. Calcium pump has the opposite function. It brings calcium from the intracellular space to the endoplasmic reticulum to make the storage. And in the opposite side, we have here the inositol triphosphate receptor, which is binded to the calcium channel. This is a ligand, a kind of ligand gated calcium channel. This is in intracellular ligand gated calcium channel. It takes the ions of calcium out of the endoplasmic reticulum to bring them outside the endoplasmic reticulum to the intracellular space. Okay, so these all are systems which control the intracellular level of calcium. Why this is Russian? Okay, I'm talking in English anyway. The scheme of the regulation of intracellular concentrations of calcium. What happens here, like in easy way? The calcium ions go inside the cell. So there is entrance of ion channels inside the cell. And here, this is due to the gated, this voltage gated or ligand gated calcium channels. Then inside of the cell we have adenylyte cyclase, which converts into CAMP and then activates the calcium ATPase, which brings calcium inside the endoplasmic reticulum. Once again, this, yes, remember. So CMP, which activates the calcium pump, calcium ATPase. This is called calcium ATPase, the same calcium pump. Calcium goes inside the endoplasmic reticulum for the storage. Also, we have guanylate cyclase. Guanylate cyclase, which is converted into cGMP and activates the calcium magnesium ATPase, which brings the calcium out of the cell, yes, which leads to decrease again of intracellular calcium. Okay, so these are our systems which we will work with when we are going to discuss the drugs which affect on the level of intracellular calcium. And we don't have it. Okay, so talking about this, what do we have? We have calcium channel blockers, as I said already, which will directly just block the entrance of the calcium inside the cell. They are verapamil, nifedipine, amlodipine, and all these drugs. Verapamil, amlodipine, felodipine, nifedipine, and all the drugs ending with dipine, lercadipine, isradipine, all these drugs, they all block just the entrance of the calcium inside the cell. Okay. Next, how we can also decrease the level of calcium? We can increase the level of CMP. How? By blockage of phosphodiesterase. We remember that not only adenylyte cyclase we also have phosphodiesterase. This is the enzyme which works actually against the CMP. Yes, it is the destroyer of CMP. It will destroy CMP. So if we use the drugs which are phosphodiesterase inhibitors, so we block phosphodiesterase, we don't have the destruction of CMP, so the level of CMP will be bigger and calcium ATPase will bring the calcium inside the endoplasmic reticulum. So we can block phosphodiesterase. The drugs which block phosphodiesterase, they were mentioned in our list here, phosphodiesterase blockers. Epricin, xanthines, papaverine, and so on. So, for example, papaverine is our drug which we have studied in narcotic analgesics. It is direct blocker of phosphodiesterase, so increases the level of CMP. What else? Potassium channel activators, diazoxide, minoxidil. Okay, let's talk about them. How do they work? We have not only the calcium channels, yes, we also have the potassium channels. But potassium channels, they are responsible not for the entrance, but for the exit of the potassium from the cell. So if we activate this channel, activate it, a lot of potassium goes out of the cell. So a lot of positive ions go out. So the membrane potential becomes lower. So it will make lower membrane potential. And if we have lower membrane potential, so voltage-gated calcium channels will automatically block because they are dependent on the potential. If potential is high, they open. If potential is low, they close. So automatically we close the calcium voltage dependent channels. Okay, then what else we forgot? venous vasodilator, sodium nitroprusside, multivitamin. Okay, what do they do? Sodium nitroprusside, for example, it is the donator of NO, nitrous oxide, yes. Nitrous oxide, it's the molecule which stimulates guanylate cyclase for the synthesis of cGMP and then activation of calcium magnesium ATPase, which brings calcium out of the cell. So we again have less calcium. Okay, so this is finally our the final mechanism of reducing the calcium inside the cell. Why this is so important to have less calcium in the cell, guys? Because inside the cell, when we have the high level of calcium, it can make the contraction of the smooth muscles. Why? We have the actin and myosin, how we call proteins, yes? Like actin and myosin proteins, enzymes, no, they are not enzymes, and proteins, which can move according to the activation of the cell. They move along each other, and by these movements, like for example, hop, check, it moves from one side to another, and by these movements, the cell gets contracted. If they can move, then the cell will contract. If they cannot, the cell is relaxed. And normally, there is a special molecule troponin, also, and a protein, troponin, which does not let these proteins to connect. You see, it is between them, and it prevents the contraction of the cell. Yes, but when we have the high level of calcium, calcium actually binds to troponin and brings it out from the actin and myosin. So actin and myosin make complex and start moving along each other. When they move, our cell contracts. So when we have less calcium, if we don't have calcium inside the cell, okay, bring it out. So here will be troponin, and actin myosin cannot bind, so they cannot contract the cell. That's why we want to reduce the level of calcium. And how do we do it? I already said. Okay, going next to the diuretics, yes. Diuretics, they are a group of medicines to regulate the volume of composition of body fluids. And they have some positive effects and some negative effects on our body. By increasing the urination, diuretics reduce sodium in our body and reduce the level of water in our body, so the volume of circulating blood will reduce. This is good for us because we want to reduce the blood pressure, which depends on the volume of circulating blood. Okay, also they give us side effects. Which side effects? They reduce the level of potassium in the blood. It is very bad because potassium, it is the essential iron for our body. Also, they can reduce the level of calcium, magnesium, chlorides, phosphates, and bicarbonates. These all are very important for the normal functioning of our systems. Okay, so what do we have here? This is our nephron, in which we can see that many different transport systems are included into the formation of the urine. So firstly, in this, how do we call it? Как это называется? Capsule, yes? Bowman's capsule, something like that. So in this capsule, we have the filtration, from which we have a lot of urine, primer urine, and then in the proximal tube, we have a lot of different transport, water and sodium and chlorine and bicarbonate ion. Then it goes to the Hentle loop, in which we have a lot of transport again of sodium, chlorine, and potassium also. Then the proximal tubule, in the proximal tubule, we have a lot of transport of sodium and chlorine and calcium, magnesium. Then finally, in the end, we have the collecting duct, in which again some transport takes place. So what are the diuretics and their groups? First, osmotic diuretics, mannitol. Second, carbonic anhydrase inhibitors, acetazolamide. Third, the loop diuretics, loop because of the Hentley loop, furosemide, bumetanide, ethicrenic acid. Fourth, thiazide diuretics, hydrochlorothiazide, chlorthalidone, and so on. 5, aldosterone antagonists, spironolactone, potassium sparing diuretics, amiloride, triamcinolone, and the herbal diuretics. So now let's talk about the mechanisms of our diuretics. So the first effect of the osmotic diuretic. So let's see. There is a lumen of the nephron. Urine here we have in the lumen, and here it will be the cells of the nephron and the blood here. Okay, what happens when we use the mannitol or any other osmotic diuretic? Here in the lumen where we have urine, we will have the high osmotic pressure. We should remember what is it, high osmotic pressure. High osmotic pressure, it means a lot of concentration of some ions or molecules in the one side, and in the other side there will be low concentration. So high concentration in the side of the lumen. In urine we will have high concentration of mannitol, of molecules. So what do we know? Water, like it is physics, osmosis process, yes? Water always moves to the place where you have the high concentration because it wants to dilute it. Like water loves the balance. If on this side we have no molecules, so water will move here to dilute this high concentration. Water doesn't like that here there is a high concentration and it starts moving. So that's why using the osmotic diuretics in the renal proximal tubule and descending limb of loop of Hentley, especially where the water permeable cell membrane we have, water will strongly move to the outside, I mean from the blood to the urine because of osmosis. So what will be? It will lead to loss of water. It will reduce the intracellular volume because from here water also will move outside, and it can make a risk of hypernatremia. Why? Because only water will go out, only water. Sodium will not go out. Sodium will be still normally reabsorbed. So that's why a lot of water just removes from the body, and it can be used in case of extremely dangerous situations like lung edema, for example. Lung edema, when you have the problems with breathing and you need to remove a lot of water at once and very quickly. Okay, we don't use this drug for the longer use, for the chronic use, because we understand that removing of so much water can be very dangerous as it can make dehydration. Next group, carbonic anhydrase inhibitors. It is acetazolamide, and the mechanism looks like that. Okay, we have again, here is, только здесь opposite. Yes, here on the right we will have urine, and on the left we will have blood, and this is the cell of the nephron. So what's going on here? We have a special transporter which brings sodium from the urine. It is reabsorption of the sodium. It reabsorbs sodium from the urine and exchanges it with H ion, with the hydrogen plus, H plus. So this exchanger should work, and it can work only with the help of carbonic anhydrase. Why? Because from where we should take this hydrogen to exchange it with sodium? From where? We take it from the molecule of carbonic acid. The molecule of carbonic acid is formed in the cell from the CO2 and H2O with the help of carbonic anhydrase. You see, it catalyzes the production of carbonic acid. Carbonic acid automatically depletes into H plus and HCO3 minus, which will be then delivered to the blood, HCO3. So what do we have here? If we use carbonic anhydrase inhibitors, for example, acetazolamide, it will inhibit the carbonic anhydrase, inhibit this moment, and it will promote the loss of HCO3 minus, and also H plus also will not be generated. So if we will have no H plus, so the exchanger will stop working and the reabsorption of sodium will stop. So if we have less reabsorption of sodium, so a lot of sodium will stay in the urine, and together with sodium, water always moves on. So a lot of sodium in the urine, more water in the urine. So diuretic effect. So the first is diuretic effect, but we should also remember that actually it is a very weak diuretic. So it is weak. Treatment of epilepsy also here is used for that. To make treatment of mountain sickness and treatment of glaucoma. Actually, from this treatment of epilepsy, we don't know the mechanism. Treatment of mountain sickness is due to less conversion of CO2 into carbonic acid, so more CO2 will stay in the form of CO2, and CO2 can stimulate our respiratory center. Yes, the humoral regulation of our respiration. And treatment of glaucoma, because in glaucoma, carbonic anhydrase also takes part in the formation of intraocular fluid. Okay, the next group, loop diuretics. Loop diuretics, as we say, they work in the Henle loop, in the ascending Henle loop. So what happens here? Again, in this place we have urine, in this side we have blood. The drugs furosemide, bumetanide, methacrylinic acid, and application of swelling and hypertensive crisis. So what happens? In Henle loop we have one special transporter, which is sodium potassium 2-chlorine co-transporter. It means it reabsorbs sodium and potassium and 2-chlorine ions in one direction. Yes, reabsorbs them together at once. Yes. So what happens here? Under the drug-free conditions, potassium back diffusion creates a positive luminal membrane voltage that is a driving force for divalent cation reabsorption. So a lot of potassium comes here, and it stimulates the secretion of potassium for the outside of the cell. Here will be a lot of positive ions, and it will provide more reabsorption of the, for example, negative ions, chlorine. Okay, what happens when we use the loop diuretics? Loop diuretics block the sodium potassium 2-chlorine co-transporter, block them. By this, we have a lot of sodium, potassium, and 2-chlorine here in the urine, and they move further to the collecting duct. So here they will go outside, and then it will lead to divalent cations to be reabsorbed more. Okay, so in this case, what will be very important? That Because of blocking of this cotransporter, less reabsorption of sodium, less reabsorption of potassium, especially reabsorption of sodium, will lead to less reabsorption of water. So loop diuretics will give us loss of sodium and water. Also, hypokalemia. Logically, less reabsorption of potassium will make hypokalemia, less potassium in the blood. And also it will increase the calcium loss because of loss of calcium and magnesium here in the collective duct. So we can say that these drugs, loop diuretics, they are quite strong. Yes, they are quite strong. And they can be used for the treatment of some hypertensive crisis or swelling. Thiazide diuretics, hydrochlorothiazide, chlorthalidone, and so on, they are used in the distal tubule, and they block the sodium chlorine cotransporter, the sodium chlorine cotransporter. What happens here? By blocking of sodium chlorine cotransporter, we have a lot of sodium in the collecting duct finally, and a lot of chlorine. Because of that, water again will be less reabsorbed. Loss of sodium and water will be, but also increased level of sodium in the collecting duct after blocking of sodium chlorine cotransporter. Here you can see a lot of sodium here will lead to enhancing of the exchanger sodium with potassium. There is an exchanger, sodium potassium exchanger in the collecting duct. So when we have so much sodium, which is the result of the use of thiazide diuretics, a lot of sodium will be here, and it will be strongly exchanged with the potassium. So a lot of potassium will go out. And again, it will make the loss of potassium. So what will be the results? Loss of sodium and water, obviously, because less reabsorption, but also hypokalemia again. Hypokalemia, as I said, it is after the effect of thiazide because of a lot of exchanging of sodium with potassium. And increased calcium reabsorption. This is here controlled by parathyroid hormone, which will exchange also with the sodium. Like our cells, they always try to maintain the normal level of sodium, but it cannot because we directly block the reabsorption of sodium. But it tries somehow to increase the level of sodium and starts using some other different ions like calcium, like potassium, to stimulate, to increase the voltage of the cells. But it cannot help in this situation. Then we go to potassium sparing diuretics. Potassium sparing diuretics, they work even after, not in the distal tubule, yes, but after that, in the collecting duct mainly. So in the collecting duct, what do we have? Here we have the exchanger of sodium and potassium. Okay, it's not directly the exchanger, it's like some transporters for sodium, some transporters for potassium, yes? And the reduced sodium influx decreases the electrogenic exchange of sodium for the potassium and hydrogen. This can cause hyperkalemia and acidosis. What happens in this place? We have, for example, aldosterone-controlled sodium channels. When we have normal level of aldosterone, it stimulates the synthesis of sodium channels and stimulates the reabsorption of sodium in this place. But what do we have? We have the drugs, red, да, вот эти, aldosterone receptor antagonist, например, spironolactone, which blocks aldosterone, reduces the expression of sodium channels, so will be less absorption of sodium. Also, we have the direct blockers of these sodium channels, direct blockers like amiloride. They directly block the sodium channel, and we will have less reabsorption of sodium. So finally, because of less reabsorption of sodium, here will be less electrogenic exchange of the sodium with potassium. Less exchange with the potassium means potassium will also not go out. When we have this reabsorption, potassium will go out because of electrogenic exchange. When we will block this by different mechanisms, this also will automatically block because it works only because of plus minus the voltage, electrogenic exchange. So blocking of this automatically blocks this. You even don't need to have any special drugs to work on this exchanger because it will automatically block when you block this one. Okay, this is how do potassium sparing diuretics. And now we will make some summary about our treatment of hypertension. So what do we see? Here we can see that hypertension can be of the first or the second risk stage, with the low and intermediate cardiovascular risks or the high cardiovascular risks. And because of that, we will have different schemes of the treatment. So, like if the patient is not that difficult, we can use the non-pharmacological treatment. It's like the good lifestyle, like moderate sport, physical activity, and good sleeping, and so on, reducing stress, yes, reducing the salt in food, and so on, and also monotherapy of the drugs. Monotherapy of diuretics, angiotensin converting enzyme inhibitors, calcium channel blockers, angiotensin receptor blockers, so beta blocker, like only one drug, yes? If we have the stage 2 or 3 or high cardiovascular risk, we should use the non-pharmacological treatment, lifestyle, yes, and also combination of the drug. We should use 2 drugs of different classes in low doses, different classes. For example, diuretic with angiotensin converting enzyme inhibitor, yes, in low doses. Then, if the target not met or intolerant side effects we have, so if these tactics do not work, what we can do? We can, in the first class, increase the dose or associate the second drug, or we can change the drug. In the second, we also increase dose or associate the third drug or change the combination. And again, if the target is not met, we add one more anti-hypertensive drug. So you see, very often we have to use combinations. We have to combine the drugs from the first class and the second class, from different groups, from diuretics, from drugs affecting on the angiotensin system, affecting on the blood vessels, bone, and so on, and use them together. So the summary. Pharmacotherapy of hypertension should be carried out taking into account the individual characteristics of the patients, the severity of the disease, pathogenic factors, and concomitant diseases. Okay, this is obvious statement. Combined therapy has great importance. As I already said, many patients have to use combined therapy. It allows to simultaneously act on several levels of regulation of vascular tone, and neutralize the side effects of individual drugs. Treatment can be based on weakening of sympathetic system, renin-angiotensin-aldosterone system, direct vasodilating action, or reducing the volume of blood by diuretics. Combinations of drugs should be administered with taking into account their side effects and possible negative effects of combinations. Why? Guys, let's pay attention. You should take into consideration this. For example, there is one very important bad combination, which is calcium channel blocker together with beta blocker can lead to cardiac, how to say it, cardiac block, atrioventricular block, atrioventricular block. Why? Because both of these drugs, calcium channel blockers and beta blockers, they all reduce the conductivity of the heart, and by their combination you can reduce the conductivity of heart so much that you will make a block, so you will stop the heart. That's why such combination should be avoided. So this is an example of a bad combination of hypotensive drugs. Other combinations are more or less good, but not this. Okay, so please take it into consideration that you should never administrate beta blockers together with calcium channel blockers, especially those calcium channel blockers like verapamil, which work more on the heart. Okay. Thank you for your attention. My name is Lorenza Mirashadovna, and my WhatsApp number you can see on the picture. Thank you guys, and goodbye.